Good morning, everybody. I'm Angel. I'm going to be hosting today's meeting. I'm just going to give everybody a few minutes and then we get started. And then I'm also recording this today's meeting for those that couldn't make it.
Recording. Even that's at least something. I can't visualize what they're talking about.
All right, Connie, I think if your team is ready, you want to get started. And if you could introduce yourselves as you speak, that would be great. I don't think everybody knows who you are.
Yeah.
Let me stop sharing.
Absolutely. Let me pull up my slides. Oh. Let me get these slides up. Bear with me while I so everyone can see this, right?
Yes.
Yep.
Okay, great. Thank you so much. So just quickly, because I want to really get into the heart of our conversation, but I wanted to introduce you to the people who are working on this initiative, at least some of us. The physician leads who are leading this are Dr. Tom Chi and Dr. Lobo. And I see that Dr. Andy Goldberg is on the call as well, and he has really been a champion behind the scenes working to get surgeons engaged in e-consent. Project managers are myself and Arpit Argawal. He's on the clinical systems side. Haley Bongo, who has developed the e-consent template in Optime, and Oscar, who is the Optime trainer, who will also demo some of the information that I'll be sharing with you. And Radiant is for radiology, which is another part of the initiative. We also have Kim Dominio, who is also on the call this morning, and she will be here to answer questions regarding risk in terms of collecting the consent from the patients in the pre-op areas and other legal risks that you might have questions about. So why are we going to e-consent? Well, there are a variety of reasons, as you can see, but several academic centers across the country, including our own UC San Diego, has adopted e-consent. And as one physician said to me, it really takes away the ambiguity of the process and who said what and when and what was documented. It's a single source of truth. It's stored electronically within Apex. It's accurate and it's clear. And also legal risks. And for here at UCSF, we recently settled a very large case as a result of something having to do with a consent. So in phase one, what we are talking about in terms of e-consent at this moment is surgical procedures. Now there's an opportunity, of course, to expand e-consents to in-clinic procedures and a host of other consent forms. But right now, this initiative is focused in these 13 pilot clinics and these surgeon champions that you see on the right that are associated with these clinics. We are in the process of planning on expanding this initiative to other areas within the system. So for this process to adopt e-consent, there is a deployment of devices. The Topaz devices, which are within the clinics, so when the physician has the conversation with the patient regarding the risks, benefits, and alternatives, the patient will sign the consent using the Topaz. And in some cases, it'll be an iPad because of space constraints. We've also been going through and training not only those pilot sites, but also in the preoperative areas at Moffitt Long, Mission Bay, Mount Zion, and the Orthopedic Institute. And as I mentioned earlier, we are in the process of training the remaining physicians in those pilot clinics. So just a quick high-level overview of the workflow and focus primarily today on the surgeon. So as I mentioned in the beginning, that conversation can occur and the e-consent process will start in the clinic, either face-to-face or through telehealth. What I will walk through with you is the process in which the patient has arrived in the pre-op area. We will pause to answer questions, and then we will do a walkthrough, a live demo of the e-consent process in the clinic, or anything else that you would like us to reinforce with you or demonstrate live with you. So in terms of risks, benefits, and alternatives, really any clinical team member can create an e-consent, but it is the patient's attending that must attest to those RBAs. It's the attending that must sign the consent before the patient or the surrogate or the guardian. The process can occur in the outpatient setting, perioperative areas if the consent has not been completed, or in the inpatient setting. And this is a shared responsibility with the team. So that means the pre-op nurses may collect the patient's signature if it was not done in the clinic or if it was a telehealth visit. And then if there are any questions that the patient might have and would like to discuss that with their attending, it is the nurse's responsibility to page the attending to have that conversation with the patient before signing the consent and entering the OR. I think you're all familiar with what the definitions are of who can sign and the definitions of a guardian or a surrogate. This is what it looks like on the status board. So what I want to point out here, as you can see that the patients that have an e-consent, you can see this small square. This indicates that this patient has an e-consent, so not a paper consent. And at this point in time in this initiative, you may not see a lot of these small squares because we're getting through to training. But as more and more physicians are trained in e-consent, this will become the norm. So how you can identify an incomplete e-consent is that it'll state one of two signatures recorded. So it'll mean that the physician has signed the consent and it's just waiting for the patient to sign. Sometimes the consent is not attached, and so the perioperative nurse will need to attach the consent to the case. So collecting the signature, and how does this occur? So as you can see in the preoperative area, down on the left-hand side, it'll say e-consent. And there you will click that on and attach it. And it will then bring up this barcode. My slides are stuck. Hang on just a second here. There you go. And in the case where there are multiple panels, each panel will require a separate consent and require signatures for each of those panels. So you will see in this case that there are 2 panels. So you will select both of those consents, and then the barcode will pop up like that. Next, you will grab the iPad that we have supplied at the different perioperative sites. You will tap hello to begin the process, and then use the camera on the iPad to scan that barcode. I think we've gotten used to this, right? With the pandemic, if you've gone to a restaurant, there's no longer paper menus, and they give you a barcode to scan with your phone. So something a little bit similar. Once it's been scanned, this will pop up and you will hand the iPad to the patient. The patient will enter their date of birth to confirm their identity. And then they can scroll through the consent, the form itself, either with their finger scrolling up and down. And let me just go back to this. So once they have signed it, as you can see on the right, and they click accept, if there are multiple consents, the next consent will automatically pop up and they will repeat the process in signing the form. So viewing the completed consent, you can see it in chart review or in the storyboard, and you can see where they have been stored and are ready to go. So a couple of quick takeaways regarding the process. As I mentioned earlier, in the e-consent process, whether it is the attending that has created it or another, a resident, a fellow, or an APP, it is the attending that must attest to them. The attending signs first, followed by the patient. And if there are any changes that are required with the consent, such as changing it from the preferred language that is documented within Apex, or changing the procedure, it will require a new consent to be completed. If for any reason that the iPad is not available, or if there are technical issues, you will need to print it out and have it signed, physically signed with the date and time noted on the paper document. So in the long run, we won't need to print the e-consents. It is all stored electronically, but certainly during this pilot phase, as we transition to this new workflow, and it is a new workflow, we recognize for everyone that printing it and placing it on the patient's bed as a visual aid for the entire team to know that it has been completed, that is fine. And oftentimes we've been asked also how to clean the iPads, and using the same cleaning products that are used for the Volt phones has been fine. So now I'd like to pause for a moment and answer any questions that you might have, and then we can move to the live demo. I'll stop sharing. Questions from the group?
I just wanted to clarify. Hi, this is Anna Meyer from otolaryngology. If you do this in clinic and you sign as attending, but the patient hasn't signed and then they're in pre-op, the nurse can have them sign without you there, or you need to be there when the patient signs?
As long as you have attested to the e-consent and you have done your part and you've had that conversation with the patient, you do not need to be there.
Okay.
Is there a time constraint on between when you as an attending can sign and when the patient can sign? Is there a limit?
That's a good question.
So this is Kim and Risk. I'll just try to address that.
Yeah.
I think as long as the patient's condition hasn't changed between the time that you consented the patient and the time they're presenting to the operating room for their procedure, then it's okay. But we usually probably wouldn't want to see, a consent that's more than 30 or 45 days aged, right? Because the patient's condition could have changed between those 2 points in time. So best practice would be, of course, as close in time as possible, but the workflow for the pre-op visits where you consent them might not accommodate that. Does that make sense?
Yeah, thanks.
This is Mary Mock from pre-op. So if the family member says, yes, I talked to the doctor, but I don't really remember what we talked about, but I consent. They're like, I know I'm having a TNA, but I don't remember everything that was in the consent that I went over with the doctor. How do we proceed?
Well, the consent form in its current e-consent phase will actually list out the risks, benefits, and alternatives. Well, the risks and benefits that were discussed with the patient, which may refresh their memory. And if they have any questions, you can, if you're able to, within your scope, answer those questions, you can answer those. The trainees can help augment the conversation that already happened with the attending at an earlier point in time, or you can always grab the attending to answer any questions the patient has.
But this is Andy Goldberg, as you're implying, if there's a question about the surgery itself, then you're going to need a member of the surgical team, whether it's the attending or the resident, to answer that question before the patient can sign.
Correct.
Thank you.
Great. I want to be respectful of the time. Oscar, can you pull up the e-consent workflow?
Sure. Good morning. My name is Oscar. I'm the Uptime trainer. Let me share my screen real quick. And I don't know, Connie, thank you. You covered a lot of ground. So I'm going to try to show you something that Connie didn't cover. Can you see my screen?
Yes.
The status board. Yeah. Okay. Awesome. So I'm just going to move really quickly just to not chew on your time on this. So I'm looking at the status board as a pre-op nurse, and because we are in a pilot phase right now, not every patient is going to have an electronic consent documented. So you'll need to differentiate which patient still has a paper consent going on and which has an e-consent. And for that reason, we created this icon, and you will see a little iPad icon. If you hover to discover on it, it'll just say e-consent. So that sort of gives you a hint that this patient is coming to the OR with an electronic consent. So you have to take appropriate action to make sure signatures are there, everything is present, or maybe possibly collect that signature from the patient using an iPad device in pre-op area. I already have pre-op navigator open here. So it's the status board, how you would, where's the tell that the patient has an e-consent. So once in the chart, right, in the pre-op navigator, you actually have an e-consent section. And e-consent section is present in the pre-op navigator, and also the circulators have in the intra-op navigator as well. So they can do some of those flows as well using their navigators. I have 3 consents here listed. Intentionally posted them in different statuses so I can kind of show you what they're going to look like. You have a status of not e-signed, where attending hasn't signed and a patient hasn't signed. It's going to be not e-signed. That's like the worst case scenario. You get an e-consent, just hang out there, nobody signed it, it's just there. Then another scenario is where a telehealth visit did happen, and an attending discussed their BAs and everything about the consent with the patient, and attending signed, but the patient wasn't present. So the patient in that scenario is going to be signing in pre-op, most likely, using an iPad. In this instance, you will see this status that Connie talked about, 1 of 2 e-signatures recorded. And then another status when all the signatures are recorded. So if the patient during COVID times decided to go inside the clinic and meet their attending surgeon face-to-face, nevertheless, then they can discuss the consent, the surgeon can sign right there, and the patient can sign right there using the Topaz device right in the clinic. And then by the time you get the patient pre-op area, the consent already has a status of e-sign. That means you just need to glance at it, make sure the signatures are there still, everything is kosher, and everything is good to go. You don't need to collect the signatures, do anything of that sort. To open the consent, super easy. Either click the link right here, the blue link, or you can click this magnifying glass, the piece of paper on the right, does the exact same thing, just pulls up the consent, and you can review it here on the computer. On the very top, FYI, you have 2 sections which show the provider and other. So provider, green check mark, that means signatures there. Other check mark, that means the patient signatures there. On the right, you have the same type of wording, but these are actual links. So I can click on provider link, and it'll take me to the provider signature. There it is. I can see the provider signed. I click on other, and there's the patient's signature box, and there's a signature from the patient, and it has a date and time on it when it was done. So that's, I would look at this, set to go, and start the procedure. Now, when you also have attach and detach buttons here. So sometimes if there are any changes that need to be made to the consent, the original consent that was created, if there's one already on the record, needs to be deleted, new consent needs to be created. That's not a nurse's job, that's the attending's job. The surgical team needs to take care of that. So if any changes need to happen on the consent, a nurse would call the surgical team and get them started on creating a new consent, so the attending then can sign it again and have the patient sign it. So changes cannot be made to any consent that has at least 1 signature in it. So once a signature of the patient is on that electronic consent, no changes have been done to it. It has to be deleted, new one has to be created. Also, so when that happens, sometimes you have to attach and detach consent. So like I have 2 consents attached. One is not e-signed, another one has 1 signature of 2. So I can detach one of the consents and then just have the correct one attached. We can clean it up that way. As you can see, when I detach the consent, this little button goes away. This button, iPad, like an arrow pointing from the top, this is the button you'll scan to get that barcode going when you are collecting the signature. And you don't see this button until the consent is attached to the case. So right here, I don't see the button. So if I click attach, and it attaches this consent to the case, you'll see the button. So I can really quickly show how that works when you're collecting the signature. So for example, I need to collect the signature for this consent that says status 1 of 2 e-consent signatures recorded. And click on the barcode or on a button, barcode opens up. And then if you want, let me see if I can really quickly, sorry, trying to fly here. Let me share screen. And I'll show you what the actual iPad will look like. Just a second. There we go. All right. So you should see my iPad screen right now, right?
Yep.
Awesome. All right. So this is what the iPad will look like when you grab it. It just says, hello, tap to begin. You literally can tap anywhere you want. And it will, on that first screen, it'll take you to this screen. It says, enter your barcode number or scan your barcode to log in. Obviously, you don't want to enter no barcodes manually. You want to scan it. So when you click scan, it'll bring up a camera. And here you can see partial barcode. And once I point it to it, boom, it starts thinking real quickly and pulls up the exact consent that I clicked that button on. Now you hand the patient this iPad and ask them to enter their date of birth to verify their identity just one more time. And so they'll put in July, this patient 6th, and then 1976, and click submit. and then the system will think for a second, and there it is. There's the consent, so patient can look at it. They can scroll up and down using their finger scrolling on any Apple device. Also, we have these buttons to scroll up and scroll down, kind of go up and down. All right, and when the patient is ready to sign, they reviewed it, they get here. To the box says touch here to sign. So this is what they're gonna do. They're gonna touch, and then put their little scribble in there, and click accept. The green check mark on the right, or they can just click accept at the bottom. Either one. I'll click sort of accept to save the signature, and I'll click accept button on the bottom. The system will think for a little bit, and this is it. Thanks for using welcome. At this point, you put the iPad away, and it resets back to the hello screen. And what you will do is come back to the computer. Here I am. So it still says one of 2 e-signatures recorded. So you would need to refresh the screen to see that signature record, because this section doesn't automatically refresh, and you have a green circle on the upper right corner of the e-consent section. I click on this button, and there, it changed from one of 2 e-signatures recorded to e-sign. And if I can review this consent now, you will actually see that here's a provider signature, and here's the patient signature as it did on iPad. And at this point, everything is good to go. Keep in mind, if there's any delays, like if the patient says, I still have questions, or, I'm concerned, I need to talk with somebody about it a little further, you, as a nurse, you contact, the team, and have somebody come down and talk to the patient about that. You always have a way of going to stop sign, and in pre-op, you do have, a consent section here where you can say consent is not present. And right here, so you said surgical consent, sign it, sign, dated, and verify. You can say no, and then put a comment, patient asking to speak with surgeon. Put that in there, and then just kind of, and let the flow take its course. And then that, the surgical team come down, talk to the patient, and click the signature later. And really quickly, I'll just show you where you can find the e-consent besides the e-consent section itself, right? That's obvious. You can go to chart review, and under scan CLIN, right here, tab in chart review, there's going to be all the consents in here, electronic consents. You can double click and see the same preview as you would from the e-consent section, as well as the easiest way to review the consents is from the storyboard. You actually have a section that says consents collected. Yes. Yes doesn't mean it's been signed or anything like that. It just says there is a consent attached to this case, but this section doesn't, the yes doesn't tell you that it's signed or not. It's just meaning that there's a e-consent attached to the case. You can click on this. It's a clickable link from the storyboard, and it'll open up a scan list page, and actually you see the consents and you see their statuses. And you can actually, if it's e-sign, you just need to review it from here. Super easy. Just click on the link. It will open the consent you click on, and you can see same screen. So you can see, click on the provider link. There's a provider signature. Click on other, and there's the patient signature. And also at the top, verify, you're looking at the correct, e-consent for the correct panel. That's kind of it. Just really flying through it. Sorry, I know we probably chewed a couple minutes of your time, but that's what I have. Before I stop sharing my screen, does anybody want me to show anything extra really quickly?
Really quick, on the
Yes.
on the navigator, this is Mary pre-op, sorry. Is there a way to, instead of just the iPad, to have that e-signed, not e-signed, one of 2 signed also, like there real quick so we could see it?
Right here, you mean? Or are you talking about from the storyboard, this place right here?
No, from the
Pre-op.
status board.
Oh, from the status board. No,
So when you look, there's not a way to see anything there.
Yeah, I mean, the only thing you see is the e-consent icon here. That's what's been built.
This is Haley.
Oh, hey, Haley. Yeah, I was going to
Hi.
say, if you're in
Yeah.
here. Hey.
I'm the build analyst on this project, and we tried to get that on the status board, like you're saying, but there's just not a way to support that in Epic right now. But we've brought that to them, so hopefully in the future we can get it on there.
Okay, thank you.
Quick question.
Hi, so this is Connie again. Just to wrap things up, since we've taken more time than anyway, I wanted to say that we will be providing the slide deck as well as the link to the playground so you can practice this workflow. One note for the nurses that are on the call, the playground will only take you so far because the iPads are not built to do that last piece, but at least you could become more familiar and practice the workflow in the pre-op section or under chart review. But again, being able to take the iPad and scan the barcode and complete it, you won't be able to do that. For the physicians though, I will also send you the link to practice in creating the e-consents in your clinic. So again, you can become more comfortable with it once it comes to you and is set up with the TOPAZ signature pads.
And Connie, I just wanted to mention something really quickly. I mean, it's kind of obvious. Maybe people know about this already, maybe not, but I just wanted to say, if there's an issue, iPad not working, whatever, and you don't want to mess around with it, something's not right with electronic collection of the signature, you always have a backup plan where you can actually open the consent and preview, and there's a print button right here. So you print it out on the local printer, and you can manually collect the signature. When you're manually collecting it, make sure underneath the box where the patient would sign, if they're using a pen and paper, there is this line right here, time and date. So make sure this is documented as well. It's time and dated right below the signature. So I just wanted to throw that in there because I just remembered that.
Thank you, Oscar. That's important.
Thank you. Yep.
Sorry, can I ask one more question? It's Mary again. If we need to add like an interpreter, does that warrant an amendment? And if so, can I print it and just put the interpreter's name and still sign if we're not changing any aspect of the consent except for that?
Yeah, I think the same rule applies. So if you are changing anything on the consent, new one has to be created. So if there was an interpreter not documented initially, then if that needs to get changed, that you'd need to create a new consent. So it doesn't matter what the change is, but yeah, if you make any changes, yeah, a new consent will be generated. So but the consents do come in, we have them available in various languages. So if initially when the provider was discussing the consent with the patient and they ended up using an interpreter, that'll probably be on there. So and they can also, the consent can appear in in Chinese or Russian, so whatever the patient can read and speak. So that's a possibility as well.
Thanks, Connie. Can I move on our agenda?
Yes, thank you so much, Angel.
Thank
Sorry
you.
for taking so much time.
That's
I appreciate
okay.
it.
I'll provide everybody with their contact information and their slides. So Anna, do you want to continue with your?
Yeah. Hello, everyone. So I am, as some of you know, Bridges coach in the School of Medicine, and my students and I have a cohort of 6 students, have been working on a quality improvement project in the OR peri-op area, and they want to update you on some of the data they've gathered, as well as the pilot project we've been working on of an intervention. So I invite my students to share their slides and we'll go through this.
Awesome. So thank you all for being here, and we're excited to share these slides with you. Titled "A Culture of Safety, Diversity, Equity, and Inclusion in the Mission Bay Pediatric OR."
Hi everyone, my name is April. I will start talking, giving some background information about projects. Some of the slides you might have seen before will be just a quick recap, and some of you, this might be new. And then my classmates will then share with you the impact of our interventions and our detailed approach, as well as next steps. So a quick summary of the background. With a lot of publication, we know that culture directly impacts patient safety and health outcomes. However, despite a lot of the importance of speaking up, it remains a difficult task, especially for those of lower power in the OR and peri-op environment. And with the index survey that was from a few years ago, we learned that 47% of the employees have experienced or observed exclusive behavior in the BCH, and 35% of employees described the current state as non-inclusive. With that, our goal is of two things. One is really we want to create avenue for all OR and peri-op staff to be heard. With that being said, that's why we sent out a survey back in late June and July to get input and comments to learn about all of your experience in working in the peri-op and OR. And we'll be sharing some of that data with you today. And secondly, we would like to develop a targeted intervention that will really enhance teamwork, collaboration, and community. So we have started a quick pilot, and we'll be sharing with you the insight and learnings we gained. And today we really want your input to see what we can do to refine and continue to improve our project. So this is a quick reminder and the flyers that we sent back in July. And just a quick reminder of some of you may have filled out the survey, and we'll be sharing the data with you.
Thank you, April. Hi, everyone. My name is Ayush Arora. I'm also part of Dr. Meyer's team. And based on the preliminary responses from the survey that we've shared with a lot of the members in this environment, we found a lot of striking results. The first being that identity strongly impacts feelings of inclusion in the BCH or peri-op space. We see that both based on role, gender, and race, there's a huge divide between those who can be considered majority or higher in power and those who are more minority or lower in power. People who, for example, are physicians versus staff. Physicians often feel much more inclusive based on their role, whereas staff feel much less inclusive. Same goes with gender. Males feel more inclusive, more included. Females feel much less inclusive, and the same goes for race as well, with majority and minority groups.
Ayush, I just want to add one small part about that for particular the subgroup of Black and African American, it was a small group. There were 8 respondents, and they were starkly different in terms of feeling non-included.
Thank you, Dr. Meyer, for that. And the same goes for the ability to share professional opinions in the OR as well. So we also ask participants, how comfortable are you sharing your opinion with your coworkers and your colleagues? And the same discrepancies existed based on role, gender, and race as well. Next slide, please. And we also asked the participants to rate the frequency of encouragement and appreciation they received in the environment. And again, those who were staff felt like they received a lot less attention, frequency in the appreciation received, and those who were female also received a lot less. And again, we see the similar trend with race as well.
And I would just point out again that smaller group of Black African American had a difference that was similar to role in terms of them compared to other races.
Thank you, Ayush. So we've seen that there's a stark difference in how people are feeling, and their experience and how they're treated, depending on if they're higher in the medical hierarchy versus lower, or majority versus minority groups. This slide is just to remind everyone a little bit about the process of coming to our intervention, which aim to stop this gap or close this gap within the culture in the BCH peri-op, pediatric peri-op environment. So we came up with 20 different interventions, and then using a pig chart, we ranked these interventions from in terms of feasibility from 1 to 20, and then decided to focus on the second, number 2, which is the end of day appreciation OR exercise. And we chose to focus on this one in particular based off of the responses from the survey, and also responses from our interviews and conversations with other staff in the environment. And a little bit on gratitude. Currently, the gap appears to be a cultural one, and this cultural gap is influencing the way that not only staff members view themselves, but are able to communicate with other members. And so gratitude is a powerful tool in transforming the workplace and has incredible effects. Some of the effects include more positive emotions, resulting in less stress and reduced burnout, greater job satisfaction, and belief by team members that they can achieve their goals. Team members being given the opportunity to express actions and qualities that they value, and team members gaining a better understanding of the roles that other team members play in the OR. And these effects all work to improve the culture and communication between the team members, which ultimately improves the patient experience and patient safety by assuring that not only that team members are recognized for their achievements and feel excited to work as part of the team, but moreover, ensuring a better understanding of the roles, actions, and qualities that are had by other team members, and increases the cohesiveness of the unit, allowing them to achieve and accomplish their tasks within cases to a higher degree, and also be present and engaged with patients rather than contemplating or being stuck on negative affects or experiences that they've had by just working or being in the environment currently. And so the first stage of implementation for this end of day gratitude exercise involved a pilot, which at a high level view included 5 surgeons and anesthesiologists who led a gratitude exercise at the end of an afternoon case before 3 p.m. Everybody in the OR went around and gave a specific appreciation to one other person, and they also received an appreciation. The responses and feedback that we received from the staff were overwhelmingly positive, and there were some constructive feedback which we used to improve the procedure of the exercise, and we'll dive into not only the responses, but the specific procedure of this exercise in the remainder of this presentation.
Thank you, Eb. Hi, everyone. My name is Adrienne Yang, and I'll be sharing with you how this pilot impacted people. So it was a success in many ways. It positively impacted people in ways as described in this slide. I can highlight a few. It uplifted people's moods. It helped people learn how to be better team members in the sense that they learned what actions others value, as well as learning the roles that others play in the OR. I'll give a few seconds to read through these quotes. And we can move to the next slide. And then we also received feedback on ways that we can improve the exercise. And we definitely implemented these suggestions, which are outlined in our formal protocol. So some modifications that were suggested are to ensure that the gratitudes are specific, that everyone in the OR gets their own gratitude, and that the exercise is well timed so that members are not struggling to finish up a procedure while trying to do this exercise. And I can also give a few seconds to read through on your own.
I'm going to add one other thing here that we've thought about who will lead this, and we've explored with several scrub techs and nurses about leading it. And this concern about the surgeon being sarcastic is a big one, or resistant. And so we've been thinking through who should lead and how we could co-lead so that people are being uplifted into leading, but also don't feel like they're going to be undermined, or that the exercise would backfire if they have lower power in the OR and receive resistance from physicians in the room.
In addition, Dr. Meyer, this is Laura. I want to say thank you to the scrub techs who spoke up and were realistic about their feelings.
Mm-hmm.
So thank you. Thank you for doing that.
It was huge. I think honesty, getting real honest responses has been really a powerful part of this process.
Concur.
All right, I think we can go on to the next one. Or Adrienne, go ahead.
Yeah, I'll pass it to my colleague.
Thanks, Adrienne. So now, based off of the responses that we received, I'm going to work through the approach that we came up with for implementing this program. So one of the first pieces of feedback that we incorporated is that sometimes it's hard to think on the moment of what kind of appreciations or encouragements to give to your colleague. And so one way to counteract this is, at the beginning of the day, inform your OR team that you will be leading the team exercise at the end of the afternoon case. And at that time, encourage the team to be prepared to share a specific statement of gratitude about a contribution from another team member. I think stressing specific is important in this case. And this will make your team members more willing to observe throughout the rest of the day, so that they're prepared to give gratitude at the end of the day. Additionally, try to pick a case that ends before 3 p.m. so that team members are not excluded, and also perform the exercise during a time that all team members are able to participate and listen, so we can get really full participation on the exercise.
And we've thought about doing it during counting, or when suture closure is happening, or the debrief. Those are some of the ones that have come up, but it's sort of a choice about what would work best. And we're still iteratively working on that. Go ahead.
Now moving on to actually implementing the exercise. So as I talked about a little bit in the previous slide, throughout the day, try to deliberately observe your team members and figure out what they've been doing well in the environment, and what you can appreciate them for during the exercise. Then, when actually beginning the exercise, explain that the team members will go around in a circle until everyone has expressed and received an appreciation. We can also welcome further appreciations if more wish to share, but that's not fully necessary. And then in step 3, the leader should start the exercise and provide a specific expression of appreciation to a team member. And here, the specific modeling of the leader is important to making sure that the rest of the exercise is specific and not just generalized feedback. As the lead of the exercise, I think it's important for the lead to pick someone who typically receives the least amount of appreciation. So here, going back to the data that we looked at earlier, it's important to think about hierarchy in roles, race and gender, anything else that you can think of. Finally, it's really important that everyone receives an appreciation in this exercise. So if someone is overlooked throughout the exercise, please take the lead and provide an appreciation for them. Moving on to the reflection piece. So after completing this exercise, you'll receive an email or survey link from Anna on the day that you complete the exercise. So please, in that email, be honest, give your own reflections and feedback on what went well and how we can improve it. And that would be great to making sure that this intervention goes well in the future. And now I will pass it on to Mulki to describe some more in detail.
Good morning, everyone. My name is Mulki. And so how will this gratitude exercise actually look? So in order to communicate perspective, we encourage the use of I statements to describe the observed behaviors and share the positive impact of behaviors. And below are a list of gratitude starters, which you can also find in a packet that we've put together that also contains a script. So for an observation, one can start with, I'm grateful for, or I appreciate that, I valued that, and then you insert the observation following that. And then the impact of that observed behavior on the person delivering the appreciation. So how it made you feel, if it made you feel inspired, and yeah, the general impact. And so for this gratitude exercise, we believe specificity and authenticity are key because we've gotten feedback that some are concerned that some of the gratitudes would be maybe superficial and just general. So for example, gratitude statements is I appreciate, and you insert the name of the person you're delivering the appreciation to, anticipated what we would need for X case, clarified those needs before we started, and had all the instruments ready to go for that complex case. It went so smoothly because of that preparation. Or I noticed that name gave words of encouragement to another person, which helped that person be successful during the first day. So an observation and then how it made them feel, both rooted in specificity and authenticity. And so I talked a little bit about the resource packet, but this is essential for leading the gratitude exercise. And depending on your role, if you're a surgeon or anesthesiologist versus maybe another person in the staff, you'll have slightly different steps. So for a surgeon or anesthesiologist, you simply pick up the script sheet and it contains just the instructions on how to conduct the gratitude exercise with examples. And if you're a nurse or scrub tech, before you pick up the script, you'll also pick up an addendum that describes how to solicit support from leaders. Yeah, and Dr. Meyer kind of already touched on this, that especially for now, we would like surgeons and anesthesiologists to lead this exercise just because they're uniquely poised to be leaders, just not in the OR room, but also for this exercise. And that is it. But also, this can be it can be challenging to conduct this exercise on your own. So we will have coaching meetings and also practice with our team available, both on request and just generally. And then I will pass on the next steps to Dr. Meyer.
Great. Okay, go to the next slide. So just to orient people, what we've done extensive interviews, we created a survey, and we collected more data from a broader survey. We've also identified champions and folks who are really amenable to do it. Those were some of the folks that did the initial pilot. And then we've tested it and received feedback and refined, which we will continue to do. Obviously, as we ask more people to do this, we will continue to refine it and understand more about how it will be effective and what some of the barriers may be. And so we're presenting it to you now, not as a finished product, but really for your input about how you think it would be best to implement this and what input we could get from the whole group. Again, this is not us doing it on our own, but really collaborating with many members of the OR space and the peri-op space. And then continue to pilot with a broader range of ORs and hopefully with different roles that feel supported, and figuring out that part that makes people feel most supported to do it. And then as we are able to refine that even further, then rolling it out to all the ORs and then surveying it afterwards to see what the effect is. Next slide. I'm sorry, that's our last slide. I thought we had questions. Anyway, so welcoming questions, input, feedback, please. I know that we have only a few minutes left, and obviously you can also email or find me in the OR if you have other things.
Dr. Myers, this is Laura. This is a great presentation, and it's a topic very dear to all of us. How do we ensure that if we want the anesthesiologist or the surgeon to take the lead on this exercise, that we disseminate this information to all surgeons?
Yeah.
How are we getting that across?
Right. So I think, obviously this meeting doesn't have everyone attending. And so I'd be curious to think through with you and this group about how best to do that, because I think there are many, one of the things is for me or others to go one-on-one and find everyone and encourage them. That's one approach. And because I think that often people don't come to these meetings. We can send out an email that clarifies this. I'm worried a little bit about the skepticism we'll still experience. So gathering more data from a wider range of people who are bought into doing it and finding a way to present that more widely to the rest of the teams that may have more skepticism. I'm curious what this group thinks. I think having the peri-op leadership, really supporting it is also incredibly helpful, which you have been, but thinking about how we would advertise that. And I see Atsuko and Hanmin and Laura, I'm curious to hear your thoughts on that, if you have ideas.
That's why I was brainstorming. That's why it came up. If we need their buy-in, so we can definitely take the subject offline. And I believe Atsuko just came on because this is a great topic.
Thank you.
Yeah, Anna, I don't, it's hard to say. Hopefully it'll be something like the universal protocol. It was a little difficult at first, but with repeated use, it became habit. And I think it's very effective now. And I think that it's going to be hard to get buy-in right away, but with time and repeated use, I think people will come to appreciate it more.
Yeah.
But I do think the leadership needs to, when we're in the room, we should often lead the project or the exercise. Yep.
Yeah, I think we'll continue to think about creative ideas and maybe run them by you, leadership as well. Like I'm thinking about as we hear more positive things, we could even send little emails each week or every other week, like this has been the impact in OR so that people can hear. I don't know that everyone reads those emails, but I'm trying to find a way to reach people so that they know what the impact is, because often the skepticism comes from, in fact, like when we heard from scrub techs and nurses, they were worried about skepticism or sarcasm when we explained that actually many people had found it to be a great experience. They were very compelled to dive in when they heard that it had already been piloted and that it had had a good impact. So I think that that's powerful. I also feel like my role as a surgeon will be to directly coach anyone who might be skeptical, and also if we hear of skepticism to go and intervene specifically with that person.
Absolutely. And so thank you for this was a great presentation. I do want to share my screen because I do want to share the first results we have from our patient experience. So I'm going to start sharing my screen really quickly.
Yeah,
with
sorry,
the
Laura, that we ran out of time. I think that first presentation went long and
No worries. No worries. Are you guys able to see my screen?
yes.
Okay. So as we have discussed in prior meetings, this is the first time that we actually have concrete data for our patient experience. We switched over from Gallup to NRC, and we are still learning the how the system works. But this is our first report for the month of July. Our N number was 77 participants. And here are the questions asked, and this is how they ranked us. So I just want to make sure that everybody, we are doing an awesome job. There's opportunities for improvement, but overall, we're doing very, very well. On the first question, would they recommend our facility? And we scored at a 90.9. The national benchmark per CHA, Children's Hospital Association, is 77.1. So we scored very well. On staff cared about me as a person, we scored at 85.5. The national benchmark is 68.7. Again, very, very well. Received consistent information in regards to care. We scored at 78.9. The benchmark was at 61.1. So those are great accomplishments, and we're going to start to disseminate this information during each combined meeting to share how we're doing with patient experience, because everything we're doing, it is centered around the patient. That's why every single one of us is here. And I want to make sure that we understand, if it wasn't for the patient, none of us would be here. So we are very, very thankful for that they completed the survey. We do have opportunities for improvement. Care providers listed, we scored at 85.5. The national benchmark was 81.2. Another opportunity was told when we could leave. We scored at 80.3. We can do a little bit better. And then this is a big one. Procedure began on time. As you guys know, we have been heavily on FCOTS. We scored at 61.8. So we have opportunities for improvement there. So we want to make sure that we share this data with everybody. FCOTS are important, and here's the data to support it. And I know we ran out of time, and I'm sorry, but we will be sharing this information on a monthly basis with the team.
I just also want to second, I think we should be really proud, and often, the operating room is often the stereotype is that we are not as good in this. And I think we really are a great model for even other parts of the hospital of how excellent we can be. So I'm super proud of our group. And for those who didn't see the announcement, I'm the medical director of patient experience for our hospital now. And so I will be working with you, Laura, and others on this. So I'm just so excited to see where we're starting, which is great, and think together about improvements we can make.
Awesome, and congratulations. And I know we're running out of time. Thank you, everybody, for joining.
Bye.
Thank you.